Tulare County has some of the highest rates of obesity, physical inactivity, and diabetes mellitus in California. Elevated heart rates has been shown to be associated with an increased risk and mortality in patients with coronary artery disease, hypertension, and diabetes mellitus. The aim of this study is to use modest increases in physical activity to decrease persistently elevated yet non-tachycardic heart rates. Ultimately, our goal is to decrease morbidity and mortality amongst the population studied.
In this study, we are going to investigate whether small increases in physical activity result in pulse decreases in patients with persistently elevated pulses of greater than 85 beats per minute on at least 3 occasions in the past year, and whether a set goal of walking 100 consecutive steps daily or general exercise encouragement exercise results in more significant pulse changes.
For our inclusion criteria, we wanted to strike a balance between capturing enough participants to make the study statistically significant and including the type of patients who would hopefully benefit the most from the study. Thus, we decided that the study participants had to have resting pulses greater or equal to 85 beats per minute on 3 or more occasions in the past 12 months. And of course, participants needed medical clearance from their physicians to participate.
So for our exclusion criteria, there are basically 3 categories of why a patient would not be allowed to participate in the study. Whether if they were not able to do it, for example, if they were non-ambulatory, if they were on a wheelchair, then they would obviously not be able to walk the steps needed to participate in the study. In addition, if they had any chronic illnesses that would hinder their health, or it would be too much of a significant risk for them to participate in the study. For example, if they had an acute myocardial infarction in the past, or if they have cardiovascular disease, or if they had any episodes of transient ischemic attacks, or perhaps even if they had COPD or emphysema, we didn't want to risk their health by having them participate in the study, so those were also exclusion criteria. And the final exclusion criteria was whether or not they were on any medications that would skew the results. And the main medication we're talking about here, negative chronotropic medications such as beta blockers, because obviously that would artificially lower their heart rate and we would not be able to get accurate data.
For our research project, we had 3 groups. In group 1, we asked them to walk 100 steps daily in addition to what they would normally do. And then at the end of the day, we asked them to record how many steps it said on their pedometer. And we made weekly follow-up calls to ensure that they were keeping record, that they were indeed writing down the number of steps that they did take at the end of every day. And we recorded their vitals before we started, and then at the 4-week mark, and again at the 8-week mark. For group 2, we did all those same things, except we asked them just to increase their regular physical activity level. We didn't give them any kind of a guidance on how much to increase it, so that was up to their decision. And we did ask them to write down what they did for exercise in addition to what their pedometer said at the end of every day. For group 3, we asked them to write down what their pedometer said at the end of every day, but we didn't ask them to do any additional exercise at all. And they still got the weekly follow-up calls, and we still recorded their vitals.
Assessment of participant compliance and losses to follow-up were serious concerns in our study. Participants were considered non-compliant or lost to follow-up in the following situations. If the participant indicated their desire to withdraw from the study, they were removed and considered lost to follow-up. If an investigator was unable to assess their compliance via weekly telephone calls after 3 call attempts, they were considered lost to follow-up. Failure to attend a vitals appointment at week 4 and 8 were also considered lost to follow-up. Finally, failure to comply with the daily activity logs for a maximum of 5 days was considered lack of compliance, and those patients were considered lost to follow-up.
So here we have our results. We first started our week 0 with a total of 45 patients, and we had some loss during the follow-ups during week 4 and week 8. And we first start with the figure 1 of the chart. Is a week 0 of the number of participants per group. We have group 1, 2, and 3, and they're equally distributed randomly. Here we have the rest of the groups at week 4. We had 23 patients lost during the follow-up, but we still had somewhat fairly evenly distributed group 1, 2, and 3. And here we have our final distribution of our 3 groups in week 8. Group 1, 2, and 3. In figure 2, we have a separate distribution given on depending on their gender of the participant. And then we have the top of the graph. A was week 0, and then B was week 4, and C was week 8. And it was randomly distributed, but we found out that more females were willing to participate, and the trend shows that they were the ones that female participants stuck with us longer than the male participants. And here are the results for each group, per group, and the male and female distribution for each group in week 0, week 4, and week 8.
In figure 3, what we see here are the mean pulses of all the participants. In figure 4, we're also looking at the mean pulses as well, but the difference is in figure 3, what we've done is, for example, at week 0, we've taken all 45 patients that we had and gotten their pulse and plotted the mean. Then we did the same thing at week 4, all the patients at week 4, and we plotted the mean. Same thing at week 8. In figure 4, however, we just followed through with all the patients who actually followed through the study through its entire period. So all 11 subjects who were involved in the study. Now, in looking at our research questions, we wanted to find out whether or not there was a difference between the groups in the pulses at weeks 4 and at weeks 8. Now, because of the small sample size, what we've done is we've used a non-parametric measure known as the Kruskal-Wallis analysis. What Kruskal-Wallis is it's the non-parametric alternative to the one-way ANOVA statistic. And because the assumptions for ANOVA analysis were not met for our study, we used a Kruskal-Wallis. In looking at week 4 data, the p-value that we got was 0.3665, and this basically shows that there was no significant differences between the pulses at week 4. Same thing at week 8, we had a p-value of 0.9934, again showing no statistical significant difference between the 3 groups at week 8. In figure 5, what we're doing here is showing results of a bootstrap resampling method in comparing the means between different groups. What this means is, first, what we do with the bootstrap method is we draw a resample of size N1, for example, with replacement in the first sample, and a separate resample of size N2 from the second sample. After that, what we do is we compute a statistic that compares the 2 groups. So, for example, in this case, what we computed for the statistic was the difference between the 2 sample means. We repeat this resampling process. In the case of this study, we repeated it 5,000 times, and then constructed a bootstrap distribution of the statistic. Afterwards, which we created a 95% confidence interval from it. So, in looking at these results, when looking at the comparison between the means of group 1 and 2, the mean difference includes the null value of 0, so there's no statistically significant difference there. And looking at groups 1 and 3, again, there's no statistically significant difference there, and the same result with groups 2 and 3. In figure 6, we also look at the bootstrap resampling method, and again, we see no statistically significant difference between groups.
This pilot study was performed to assess the feasibility of performing a larger study throughout the clinic network. Encouraging small increases in physical activity to decrease cardiovascular morbidity and mortality is exceedingly difficult when working with low socioeconomic status and non-compliant patient populations. Exercise encouragement in health centers requires constant follow-up and dedication on the part of both staff and participants.
Participants require access to safe exercise locations and transportation to follow-up appointments. Patient compliance is also limited by poor understanding of instructions and hesitancy to ask questions, especially when investigators and participants speak different languages and translation is required. Exercise should be encouraged in all patients, but at this time, our study cannot conclude whether 100 steps is beneficial in decreasing heart rates, and further study is required.